So now we're going to talk about biomechanics of the spine. So this is important for rehabilitation. If you understand what the spine does and why it does, then you can start to think about how to reverse these things. So biomechanics is a huge and important part. So the spinal function, again, we're going to go through this once more, provides enough flexibility to allow positioning of the head and trunk in space. It has to have strong resistance to excess motion that could damage the cord and nerves. The ligaments and discs are passive resistors and dampeners of motion. Tendons and muscles are active stabilizers and prime movers. So we're going to talk again about the anatomy. 70% of the weight of the spine is carried in the anterior column with the vertebral bodies, the discs, the anterior and posterior longitudinal ligament. Conversely, the facets carry 30% of the weight and mainly resist shear forces. The discs absorb shock and allow motion, but have poor resistance to shear forces. That's important as we start to find out how the spine breaks down. Shear forces are highest in the lower lumbar vertebra because of their angle and the sacral angle. Discs are lordotic and responsible for lordosis and in the thoracic spine kyphosis. And the spinal canal and foramen in the posterior 1/3 of the spine behind the center of rotation. A very important point that has a lot to do with pain generation. So, facet anatomy. Facets are connected to the spine through these very strong structures, the pedicles. The superior facets are directly embedded into the pedicle, and the inferior facets are connected by a thin bony bridge called the, everybody's mumbling but afraid to commit, pars interarticularis. That's the pars interarticularis. Facets prevent shear forces to the disc, so are highly important. The ligaments, the anterior longitudinal ligament right here, tightens with extension, right? Since the center of rotation is here and you bend backward, everything in the front gets stretched. So the ALL stretches, the anterior disc stretches, and compression is pushed backwards. So the posterior longitudinal ligament tightens with flexion. Very important point. When you see double stars, that's important. The PLL has more stretching capacity than the posterior annulus. Why is that important? Because the PLL cannot protect the posterior annulus when you bend forward. So you can tear the posterior annulus with an intact PLL. So posterior element physiology. So facets, as we've talked about, are restraints of motion. The angles of the facets vary from male to female. Another double star, very important, right? Females have more sagittal orientation, meaning they're more front to back, where males are more coronal or more side to side. There's more shear resistance in a male facet than a female facet because we think females were designed to deliver babies. So the pelvis has to open a little more, so there's less resistance to that, which creates problems. The spinous processes, again, are flexion restraints and are extension blockers. And the ligamentum flavum is very important. It's also a flexion restraint, but it has a special quality. We call it the yellow ligament because it looks yellow. And that is because it has a high concentration of a specific protein called elastin, which is found in only 2 other areas in the body for the most part. Everybody know? For bonus points? Ear and the nose have elastin. And it has to be here because this is a thick ligament in back, and if it becomes too bulky, can create narrowing in the canal, which will come back to rear its ugly head in the future. So that's important to know. So this is a normal MRI, and I want you to understand the anatomy of the foramen. This is the spinal foramen, or the area the nerve root exits out of. You'll notice that the spinal foramen, more than half of the height of the foramen, is made up by the intact disc. So what happens when you get disc narrowing? you start to lose foraminal height. What happens if you then get an enthesopathy? A bone spur. You narrow it even more. So you're starting to put together the ideas of how spines fall apart. You start to get degenerative changes, too much pressure on the facet gets a bone spur, and you start to get foraminal narrowing or foraminal stenosis, right? Okay. Values of motion for individual lumbar motion segments. Why is this important? Because when you look at somebody and you're trying to figure out where their deficiencies are, you have to know what normal is. Again, you have to memorize nerve root distributions, myotomes, and angles and range of motion. So if you look, a way to sort of get an idea, everything has greater than 10 degrees, and it's the highest in L5-S1, and it drops at each level. So total range of motion for the average spine is 80 degrees. And that's because L1-2 is less, L5-S1 is more. Lateral bending, it's a little higher in the mid-back than in the lower back because of ligaments we'll talk about later. And rotation, highest at L5-S1. Which disc do you think wears out the fastest? 5-S1. The most mobile disc is the one that also has the most stress on it. Sacroiliac joint, as we talked about, diarthrodial and fibrous portion. Range of motion of this joint is only 1 to 2 degrees. Aging joints have less range of motion. Only rare pain generators. We'll talk about how to diagnose this. This is actually a hot controversial topic right now that we'll see. So sagittal alignment. The L5-S1 disc is on about a 45-degree slope going downhill. Center of C7 should come right over the sacral ala. The normal lumbar lordosis, 60 degrees. Normal thoracic kyphosis, 20 to 40 degrees. Normal cervical lordosis, 30 to 40 degrees. So you have to remember these numbers because you're going to measure them on X-ray, because X-ray is going to become one of your most valuable tools. Okay, disc thicknesses. Discs get thicker by an average of 0.5 to 1 millimeter at each level. So here, this one's about 10 millimeters. It's about 10 and a half. It's about 11 and a half. Ah, that's 8. Wait a second. And that's almost 12. What's going on here? What's happened? Degenerative disc. You don't need an MRI to look at an X-ray and figure out what's going on. But you can measure these specifically. They should get thicker as you go down. This one, L5-S1, interestingly enough, even though it has the most range of motion, is one of the thinnest discs in the lumbar spine. Normally, L1-2 is a little thinner, but L5-S1 is no more than 12 millimeters most of the time. So, the anterior core muscles, the rectus, the external and internal obliques, attach superiorly from the ribs to the front of the pelvis. Laterally, these muscles do not directly attach into the vertebra, but into a retinacular sheath then attaches to the spinous processes, meaning anterior muscles cannot directly affect position of the vertebra. It's a generalized contraction. When activated, these muscles cause dorsoflexion, lateral bending and rotation, and also compresses the abdominal contents. I can tell you've got a bad disc. Sorry. So, posterior muscular connections. The lumbar extensors, the quadratus lumborum and erector spinae, attach from the sacrum and the pelvis to the thoracic spine. There are some small attachments to the lumbar spine, but the attachments generally start at the vertebra and ascend, not descend. There are no muscles that insert from the pelvis directly into the vertebra except for the quad lumborum and some multifidi, meaning that you don't have direct control of positioning for the most part. The muscles that do that, the multifidi and rotators, are small muscles that don't have the strength to resist certain types of motion. So we are born with problems that we can't easily identify and help unless we learn how to do things appropriately. So, the spine has multiple movable segments in 6 degrees of freedom. There are no strong, direct muscle attachments for 3 of the 6 directions the spine can move, because the spine can flex, extend, laterally bend, and rotate. The muscles that control the spine have significantly more work and coordination than any other region in the body. You have an elbow. You've got a biceps muscle to contract and flex it. You've got a triceps to extend. You've got a little bit of supination, pronation, yes. But it's a simple joint. And when you contract a biceps muscle, everybody here has heard of reciprocal innervation and reciprocal inhibition. Most everybody has. So the body naturally says, okay, contract the biceps, relax the triceps. You don't want to engage both because you're going to jam the joint, right? We don't have that in the lumbar spine. There is no reciprocal innervation, reciprocal inhibition. So, let's talk about the Multifidi. They act more as stabilizers and not as prime movers. Their principal action is extension of the lumbar vertebra, and the role of the Multifidi is to resist flexion shear forces. I hear a lot of talk about Multifidi, but they can generate 60 newtons of force per muscle, and we'll go through the biomechanics of the spine. There's times where you need 8,200 Newton force to resist. So the Multifidi is overpowered. So there is the normal lumbopelvic rhythm. With normal bending, the spine itself flexes first, or actually loses its flexion. So when you start bending over, the hips are maintained normally. The spine first starts to straighten, and then you bend through the hips. This is a normal rhythm that everybody develops. And this is what it looks like. You have 60 degrees of lordosis. The first thing you do is remember the lumbar spine has a total of 80 degrees of range of motion. Well, the first thing you do is you lose that entire range of motion and you're flexed 20 degrees when you start bending. Then as you continue bending, this is locked and you go down through your hips. So pelvis moves 35 to 40 degrees after full lumbar flexion. So if you look at it, the spine moves the most, but in reality, the hips contribute at the very end. So pelvic rotation and muscular contraction. So what can happen to the pelvis? Well, you can tighten the hamstrings, and the hamstrings are going to do what to the pelvis? Posteriorly rotate. What is that going to do to the sacrum? It's going to flatten it, right? So it flattens the sacrum, so there's less shear on the sacrum. So if somebody comes in with a disorder where they've broken through their pars interarticularis, remember the bony part that connects the facet to the upper vertebra, and they're miserable, they want to reduce that shear force because they've lost their doorstop. So what are they going to do? They're going to tighten their hamstrings to rotate the pelvis backward to reduce the shear force. So they're going to have hamstring contracture. So you can affect the pelvis by pelvic station, meaning that depending on the disorder, you want to teach them to have a flat back or maybe have a hyperlordotic back, depending on the disorder. Let's see if I've covered everything here. Okay, well, we talked about, yeah. Okay. So, disc height changes. Pressure on the disc when upright, we remember, reduces the height of the disc. Recumbent position reduces pressure, allowing imbibition to fully rehydrate. Theoretically, less nuclear pressure might allow greater chance of annular stress later in the day, meaning you have a higher chance of annular injury as you've been standing all day. If you're sitting in bed, eating Cheerios and watching TV, then you have less chance of injury. So, pressure drop of the nucleus due to cellular disruption reduces the interstitial matrix volume. You lose height, the car tire loses air, so to speak. The pressure drop increases annular fiber stress, resulting in potential overload. So we start with the degenerative disc. You're later on toward the middle end of the day. You have less pressure in the disc. So Remember, the annular fibers are angled 30 degrees to each other, right? So rotation will do what to the disc? It'll reduce the strength of the disc by 50% if you rotate. The fibers aligned with the rotational direction are put under tension, and the opposite laminate fibers are unloaded. So just by rotating, you lose 50% of the strength of the disc. Then you bend. So when you bend, what happens to the front fibers? They're slackened because of the center of rotation. The posterior fibers are put under stress. So now you're starting to put a picture together. You bend forward, you load the posterior fibers. You rotate, 50% of the fibers now are unloaded and the other 50% under a maximum load. And then, well, here's just another picture. When you bend, the fibers in back are under stress, fibers of front under a compressive stretch. So, you can injure these fibers. This is called a stress-strain curve. There are 3 zones of injury. There's the neutral zone, where you can move within the zone and there's not much change in the collagen fibers. You can get into the elastic zone where you see the strain or load really increases, but as long as you're within the elastic zone, you're not going to injure the disc. But if you get into the plastic zone, this is when you get disc injury until you get failure and a tear. So you can damage the fibers while they're still intact. So it doesn't have to be one bend and twist, it can be multiple. And this shows you what I like to call the running start. So if you have a normal disc, if you look here, this is how much displacement occurs, and this is time. So in a grade 0 or non-degenerative disc, it takes a while before it displaces, and it displaces slowly and doesn't go beyond 1/10 of an inch. But a grade 3 degenerative disc, once you start loading it, there's no time to recover, and it immediately goes up to 0.2 of an inch. So that means that once you load, if you don't engage your core before that, you're creating a running start and you're going to create an injury. So I'm trying to plant some seeds here so you guys understand the biomechanics and understand how to prevent injuries. Injury prevention is so much better than trying to put the genie back in the bottle. This is a famous, remember, medical students will do anything for money. So Alf Nachemson back in Sweden in the 70s said, I want to put a needle into your disc and measure the pressure. And he did. And he did it at L3-4. And interestingly enough, this is the pressure diagram that he developed. So when you're lying down on your back, the pressure is the lowest it ever is in your disc. When you lie on your side, it triples, believe it or not. When you stand up, it goes up to 100. Bend forward while standing 150, and bend forward standing with the weight 220. Now, this is interesting. I'm not sure I understand exactly why. Sitting in a chair really loads the disc even more. That's probably because you're flexing more with your knees bent. But the highest weight that he was able to get is a sitting position and a load. This is the diagram to understand how to prevent injury. If you look at the fulcrum point, remember Archimedes' principle. Let's see, I have Archimedes' principle. You have a fulcrum, you have a weight, and the opposite side has the same match as the weight. So if this is 60 kilograms and this is right in the center, you have a 60 kilogram load to hold that weight up. Well, what happens if you take the fulcrum and you move it way over to the stress area? You're going to logarithmically increase the amount of load necessary. So look at this diagram with the individual lifting with his knees bent and close to the body. And then look at this diagram. This is what happens with people when they load, when the object is way too far out, they triple, quadruple the load to their spine. So let's go back here. So here's the load right here. You have a fulcrum right here, right where your hip is and your sacrum is. And then the load can be magnified. The further you reach out, the further your arms reach out. You're loading your spine. You're set up for disaster. So the first thing you have to remember, either lifting yourself or teaching your patients is to keep it close to the body. Huge, huge deal. So, what do you have to worry about? I like to use BLT because everybody remembers bacon, lettuce, tomato. It's bend, load, twist. So if you are in a position, flexion causes all the posterior annular fibers to be under tension. Rotation causes 50% of the annular fibers to offload, meaning you lose 50% of the strength. Remaining fibers load under tension, and then you load the spine with the weight further from the body is going to cause an annular tear. This is how it occurs. Now, some people can do it for the rest of their lives because genetically their collagen fibers are fascinating. I don't know why they don't tear, but they can do it, but other people can't, like me. And so you end up with annular tears. And again, we talked about this. The nucleus is full of inflammatory factors, metalloproteases, arachidonic acid, cytokines, and the tear allows the nociceptor within the disc wall to be contacted by all of these miserable factors. What happens to the nerve root? Or not the nerve root, the nociceptors within the disc wall. They become inflamed. Why does it take sometimes a while for them? You bend down, you have a pop in your back, you say, that was weird, and the next day you can't walk. The inflammatory cascade, right? It takes a while for the arachidonic acid to go down the leukotriene and cytokine pathways. So, this is what an annular tear looks like on an MRI. This says a tear through all 30 fibers. You can only tear through 1 to 5 fibers, making a weak spot for future tears. But HNPs, herniated discs, are generated. Actually, there is a little bit of nucleus out here, but the nerves aren't compressed. This guy just had back pain and no leg pain. And again, this is what a new annular tear looks like. This one was accompanied by a disc herniation too. That's why we have a picture. I don't go in there for just annular tears, just to let you know. So, center of rotation, hugely important. We talked about it. There's a paper in the 70s by a little guy named Svante Rolander out of Sweden who did biomechanical studies on normal spines and on degenerative spines. Normal spines, the center of rotation on extension is here, on flexion is here, and left and right lateral bending is here. And then he found degenerative spines, the center of rotation varied so much that you couldn't predict. So there are times when you'd expect a pain to be from extension because they have narrowing in the canal, and it doesn't occur because for some reason their center of rotation is behind the facet. So it's not perfect science because you don't know where your center of rotation is. But in general, you can make some rules that we'll talk about. So, in neutral position, the disc is neutrally loaded. This is not correct. Why is it not correct? Why is that picture? Exactly, the disc is parallel. Discs aren't parallel. When you flex, the center of rotation is in the front. You open up the foramen, you open up the spinal canal, you put pressure on the annulus, you distract the facets. When you extend, you do the exact opposite. Everything in the front is under tension, everything in the back is under compression. You narrow the foramen, you narrow the canal, you imbricate the facets. So if you know this, you can use these facts to figure out what's going on with the patient. So what happens if you have narrowing of the lateral recess? What's going to happen to the root when you bend backward? If you don't know what red means, then we have to talk. So you're going to compress that root. If you bend forward and you have problems with the disc and you abut the two bony surfaces, you're going to create pain in the disc. So somebody who bends backward and has leg pain, what do you think in general is going on? Foraminal or lateral recess stenosis, or maybe even central stenosis. When you bend forward and abut the vertebra, what happens? Bone. So if you have a crappy disc, you have no cushion left, you're bone on bone and you load in front, it's going to be more painful. So now you can start to put together, this guy's got back pain when he bends forward, leg pain when he bends backward. You start to formulate a diagnosis. So, central stenosis. That's narrowing of the canal. Yeah, please.
If someone's got pretty good disc bulge and bending forward, and that's really causing extra compression going back, do you see that as a...
Interestingly enough, if you have a disc herniation and it's the lower discs 4, 5, and 5, 1, bending forward stretches the nerve root over the disc herniation, and they'll get increased radicular pain. Patients with fresh disc herniations that have radicular pain, they're standing up in my office, almost bending backward, walking around like this, because they don't want to sit down. But if that herniation is big enough to create lateral recess stenosis, they're damned if they do, damned if they don't. Bending forward causes leg pain, bending backward causes leg pain. So we'll talk about how to differentiate that as we go down. So central stenosis occurs by narrowing of the central canal. And this is what happens. You get disc bulging, you get facet, what is that? Enthesopathy, okay. Yeah, bone spurs. And then remember the ligamentum flavum. Ligamentum flavum doesn't show on this diagram, but does show here. So you bend forward, and the ligamentum flavum comes out of the canal. You bend backward, it bunches up in the canal and creates compression. So here's a critical factor. Bending forward creates what kind of pain? Bending backward creates what kind of pain? That's going to be part of your differential to figure out what's wrong with the patient. So this is an actual myelogram, not Pantopaque, but regular water-soluble myelogram. You inject dye in the canal, this patient bends forward, look at the canal there. The patient bends backward, what happens to the canal? Narrows. This is why when people stand up with central stenosis, they feel like crap and they're looking for a counter to lie on or a chair to sit on, or a lot of them will be walking and just crouch because they want to get that nerve to function again. Exact same thing as resting your ulnar nerve on the side of the arm, right? You're going to rest it on a table, it goes to sleep. You get away from it, it's a dynamic compression. So in dynamic compressions, where I'm going to advance the question, will you see a neurologic finding on exam? Correct. If the person knows they're having pain and they're going to get off that root's not going to be damaged. So if you do a physical examination and you examine them, you're going, God, the neurologic exam is normal. What the hell's going on? Well, bend them backward. Ah, okay, there it is. It's dynamic. It doesn't have enough time to create an injury to the nerve root. So, basic rules of flexion. This is going to be important for treatment. Flexion compresses the disc and offloads the facets and pars defects. So bending forward obviously loads the discs. You unload the facets. You open the canal. So flexion places the posterior annulus under tension. So if you got an annular tear, what's it going to be like? Bend forward? I don't like that. You want to bend backward. Flexion opens the canal, both central, lateral recess, and foramen. It increases the shear forces in the lower lumbar vertebra. So for patients with slips, they're not going to like that because it increases the slip. Is it going to increase their leg pain? Do this. No, because bending forward opens the canal, right? It's not going to increase their leg pain. Flexion increases the shear forces, as we talked about, so patients with a spondylolisthesis are going to have increased pain for the most part. Flexion stretches the sciatic nerve and relaxes the femoral nerve. This is important. The femoral nerve goes where, the sciatic nerve goes where? Just basically in the pelvis. Femoral nerve goes in the front of the pelvis, down the front of the leg. Sciatic nerve goes in the back of the pelvis. Think of a cable on a pulley. When you bend forward, what are you doing to the sciatic nerve? You're stretching it, you're elongating it. So sciatic nerve problems, that's no good. You bend forward, they don't like you. What happens to the femoral nerve when you bend forward? It relaxes. So people with a femoral radiculopathy will like to bend forward. Patients with a sciatic radiculopathy will not want to bend forward. So little differentials that are important to remember. Basic rules of extension. So extension narrows the central canal and the foramen, right? So if you've got stenosis, you're going to make this situation worse. If you've got narrowing in the lateral recess or in the foramen, you're going to make it worse. Extension reduces the pressure on the disc, unless you have IDR we'll talk about, but compresses the facets. Patients with bad disc pain want to bend backward all day long. You bend them backward in their office and they go, I like that. But if they have bad facets, what are they going to do? They're going to yelp at me. You bend them backward, you load the facet. They don't like that, right? So lateral bending with extension compresses the ipsilateral foramen. So you bend backward, you compress the foramen. They have right foraminal stenosis. You lean them over to the left. What happens? You open the right foramen. You lean away, you open it. So not every patient, but if you lean them back with leg pain, you lean them to the opposite side, their leg pain can go away. That's a pretty good indication, lateral recess or foraminal stenosis. You lean them to that side, what happens? It gets worse, right? More leg pain. So again, these little tools can make life easier on exam. Now remember, herniated disc patients at L4 to S1, which are the foramen or the sciatic nerve, they like extension. They want to bend backwards because it offloads their nerve. But patients with femoral compression, you bend them backwards, they don't like you because you're stretching the nerve over the herniation. The little things. But we'll talk about exam and how on an exam you can figure out what's what. Okay, pelvic rotation and lumbar lordosis. So pelvic rotation, yeah, please.
Yeah, about the pars fracture, is that dependent on the chronicity of the problem? In other words, if it's a more acute fracture, is that like this?
More acute fractures aren't displaced and won't have created at that point foraminal stenosis. So you bend kids with fresh pars fractures. We have a whole course on that we'll talk about. You bend them backward, you load the fracture, they'll yelp at you. You bend forward, they'll like you. Yeah, but that's before they develop foraminal stenosis and slips and things like that. So, why is pelvic rotation and lumbar lordosis so important? Because changing the rotation of the pelvis changes the orientation of the lumbar spine. You anteriorly rotate the pelvis, you increase the lordosis. What is that going to help? Degenerative disc disease, right? Increase the lordosis, load the facets, offload the discs. Patients with degenerative disc disease love to be extended. So if you're going to rehabilitate them, you've got to teach them how to increase their lordosis. What's another way to do it if they're going to sit? What can you do? Yeah, a lumbar corset, a lumbar pillow. Extend their spine. As they sit, we tend to flex. Patients with bad discs tend not to flex. If you put a lumbar extension device, like a little pillow behind their back, you'll extend them. They'll like that. So you start to put things together. How can I treat these things? So one of the things you want to do is you want to learn how to change the orientation of the pelvis. Posterior rotation, again, reduces lordosis, increases disc pressure, reduces facet loading. Patients with bad facets love to flatten their lumbar spine. Patient with stenosis, flatten their lumbar spine. I had a guy come in from Aspen, and I talk about the Flat Back Club. And he had terrible stenosis. So what I do is I push him against a wall, and I put my hand behind their back, and I said, crush my hand. So he flattens it out, and of course you have to abdominally contract. And he said, walk away from the wall. And he looks at me like I'm a retard, but he walks away from the wall and he says, I don't have any pain. He has to be trained in that way. He's now part of the flat back program we talk about, like the Flat Earth Society. So, facets. The articular cartilage is 70% water, and it's responsible for cushioning bone from impacts. When the disc degenerates, it increases the pressure, and aberrant motion causes cartilage fibrillation. What are all these little things here? Bone spurs, enthesopathy, right? So it causes spur formation and foraminal or lateral recess stenosis, And the cartilage erosion makes the facets incompetent, allowing for a slip. Remember we talked about the door stops. This is the first step in a degenerative spondylolisthesis, which we'll cover. Enthesopathy, the same picture. This guy, I don't know how he lived with this thing, but he did. So again, Sharpie's fibers connect annulus to bone. You pull them off, you get a bone spur. So patients who come into you and they have this presentation. So I straightened this guy's knees, and what's happened to his spine? So he's forward. So what do you think is going on here? He's got well, it could be. There's a differential diagnosis. People who come in with this can have a number of different things. So what happens here is if I straighten his legs, his back flexes forward because he normally stands in a bent knee flexed forward stance to balance his spine because he can't rotate the pelvis far enough back by balancing, so he has to bend his knees. So if you see this, you want to look for things like antalgia. So here's a gal, bent knee, flex forward stance. She may have antalgia. What's antalgia? Yes, it's a comfort. So you're adopting a position of comfort because any other position can create pain. So she may have antalgia. She may have central stenosis, lateral recess stenosis, or foraminal stenosis. That's one of the things. Number two, degenerative disc disease with flat back syndrome, right? We saw pictures of that already. If the disc goes away and the disc is trapezoidal, it makes your back flat. You can't stand up straight. You have to bend your knees. She can have facet pain or spondylolisthesis. So it hurts to extend backward. It's rare, but you have to have that in your differential. Thoracic hyperkyphosis. If her thoracic spine is hyperkyphotic, how do you balance that? You try and extend back, but if you can't extend back far enough, you bend your knees. It's another presentation. And finally, hip and knee flexion contractures can cause this too. So now you have a differential of things that cause flat back. Somebody comes into your office, you can start looking for these things. That's what you do. So, flat back, this is a flat back syndrome. That's 20 degrees. What's normal? Got to memorize these things, 40 to 60. So this person can't stand up straight because their discs are gone. They not be able to extend much on flexion and extension x-rays because their backs are locked. The motion comes from the disc. You don't have a disc, you don't have motion. So, flat back stenosis. This patient has a large disc herniation causing central stenosis. These patients will have the same exact presentation as the other picture you saw, except for one difference. What's that difference? You bend these patients back, and what are you doing to their roots? Crushing them. So you bend them backward, they're going to have buttocks and leg pain. And then you bend them forward, they're going to feel better. So there's a differential already. You can differentiate between flat back syndrome and lumbar stenosis. Also true in lateral recess and foraminal stenosis. Okay, isthmic spondylolisthesis. So this, here's the vertebra. Here's the back of the vertebra. This is what I call the doorstop. What do we call this area? The pars interarticularis. And it goes down to the inferior facet and keeps this vertebra from sliding forward on this one. But is there a problem here? There is. There's a break. And that break has allowed this vertebra to send itself forward on this one. And that slip is caused by this defect. And this, if you try and straighten up, what are you doing to the fracture? You're mashing it. It hurts. So what are you going to do? Bend forward. Well, how are you going to compensate? Bend your knees, right? Same presentation, different reason. And finally, there's one more, but thoracic hyperkyphosis. This is a patient that has something called Schurman's disorder, which we'll talk about later. But this person over the years has developed this large kyphosis. What's normal? 20 to 40? I knew everybody was going to tell me that. So this is 72 degrees. How do you compensate for that? Extend your back. Hyperlordosis. If you can't do that, then what do? Bend your knees. Another similar presentation, but if you have a good eye and you look at the thoracic spine, you'll go, you got a big hump there. And so you can differentiate it just by looking. And then finally, hip and knee flexion contractures. So if your knee is contracted, you'll stand with a bent knee gait. And if your hip, you have a hip flexion contracture, you're going to do the same thing. So now differentiate scoliosis in antalgic positioning. So if you see this, is that scoliosis or antalgia? Why? Because of rotation. Well, first of all, the whole spine, unfortunately, is falling apart. Look at L4 and L5. The whole thing is shifted over. That's a rotational change. Do you see? If you look at the vertebra and you find the, I like to say, the allies and the albeak. The allies should be equally fine from the beak. If there is translation for, here's the beak here, there's an eye there and an eye there, much greater distance here than here. So you look at that and you go, that is a condition where there's rotation. Antalgia, meaning positioning to try and prevent pain, doesn't have rotation. So you can look, and if once you see rotation of the vertebra, you know this is going to be a scoliosis. Versus this one. So you look at it, and you see the vertebra, you see the two allies, so to speak, in the albeak, and they're pretty much midline. There's no rotation here. This is antalgia because somebody's got a big goomba right there, and it's causing him to lean away from that area. So that's an antalgic positioning. Okay, what time is it now? 10:30. Let's see what we have here. Questions?